Hello once again from this side of the internet. Thank you for being here with me for another episode of A Conversation With. Today we are sharing a special episode in recognition of National Fentanyl Awareness Day, and we're sitting down and talking with Dr. Kelly Ramsey. Now, you may have caught her recent Treat Addiction Save Lives podcast episode from the 55th Annual ASAM Conference last month, which was a really great episode, so be sure to check that one out and give it a listen. But she was kind enough to stop by and chat with me again about everything from how the separation of addiction care from the rest of healthcare feeds into stigma, as well as the current issues facing addiction medicine providers when it comes to things like fentanyl and polysubstance use. Dr. Ramsey is a board-certified internal medicine and addiction medicine physician who has treated substance use disorder since 2004, and she has worked as medical director of an academic center-based opioid treatment program in the South Bronx before working for nearly a decade for a large federally qualified health center in the Hudson Valley, where she created and grew a medication for addiction treatment program for opioid use disorder and alcohol use disorder to 10 sites and 1,500 patients. Wow. More recently, Dr. Ramsey worked as the Chief of Medical Services at the NYS Office of Addiction Services and Supports in a policy, regulatory, and clinical role. Dr. Ramsey currently works as an addiction medicine and harm reduction consultant, as well as providing low-threshold clinical care and clinical supervision in addiction medicine in 3 drug user health hubs in New York. All right, now let's get into today's talk with Dr. Kelly Ramsey. I want to ask you about how addiction treatment, sometimes it seems like it feels like a space that exists kind of on its own. And there's a quote from Dr. Jerome Adams and Dr. Nora Volkow from a 2020 article entitled Ethical Imperatives to Overcome Stigma Against People with Substance Use Disorders. And in it, they say, separation of addiction treatment systems from the rest of healthcare in the U.S. both stems from and feeds stigma. So can you explain a little bit to me about this symbiotic relationship and how that cycle continues to perpetuate? And what do you think can be done to kind of break this pattern down and reshape a little bit how addiction treatment is viewed?
Sure. So there is a siloization in medicine for a lot of different disorders. So it's not specific necessarily to substance use disorder. It also happens with mental health, also happens to a degree with HIV, et cetera. So I think of it like this siloization tends to happen with conditions that are more stigmatized. So again, not just substance use disorder, but other conditions as well. I think initially with some of the siloization, it had to do with privacy and protection for the individuals with said conditions. So when we think about HIPAA, but then more specifically 42 CFR Part 2, which really covers mental health, substance use, HIV, other conditions, which again, people may face stigma if their condition is revealed. So it may have come from a place of trying to protect people, but the unfortunate result is by separating out particularly mental health from primary care, the rest of medical care, separating out substance use disorder care from the rest of medical care, you create an other. And there are many providers in the healthcare system who just don't want to treat the other. And so that othering, unfortunately, reinforces the stigma. So instead of substance use disorder treatments, such as prescribing buprenorphine being integrated into primary care, just like any other disorder, whether it's diabetes or hypertension, instead, a provider will respond, oh, I don't do that. I don't treat them. They get treated over there by somebody else. And so that is how I think it does reinforce it. Because even when you try to introduce elements of treating individuals with substance use disorder and mental health back into the regular medical system, there's still a lot of doors that are closed to that happening. We do have models of integrated care that I think are emerging, in which it's no wrong door for entry, regardless of what condition you have. But I think we still have a long way to go. And if we don't break down stigma towards individuals with said conditions, we're never going to get there, unfortunately.
Right. You also, I know you've mentioned in the past that there's a cycle of drug-related stigma, and that stigma can lead to issues. And I don't know if everyone thinks about these things, but, poor health service access, poor social and emotional well-being, marginalization, and risky behavior. So can you tell me a little bit about this idea? How does stigma bleed into these other areas of a person's life and start to impact those spaces? And, what does that look like? How does it influence and affect a person?
So people who have experienced stigma in the healthcare space are reluctant to enter that space again. So what that can mean is delay in care. So for instance, a perfect example that's happening currently are skin wounds related to xylazine. So individuals will unfortunately sometimes let a wound progress to a situation where it's far more severe than if they had sought out care earlier, because they don't want to go to the emergency department and experience the stigma that they've experienced there before. And so it leads to internalized stigma. So individuals will believe the stigma that they're being faced with. So if they're treated disrespectfully and treated with vilifying names, for instance, then they will internalize that. And often it affects somebody's self-worth and their self-esteem. And then that can lead them down a pathway of, then what's the point of not using? I'll just keep using. And so it really delays access to care. It delays entry into care. And obviously, if you delay access to care, delay entry into care, that's going to lead to worse health outcomes for individuals. So whether it's a pregnant person who's actively using, who doesn't want to engage in prenatal care for fear of being stigmatized, and therefore doesn't engage in any care, and then has a worse outcome in their pregnancy for both themselves and their newborn because they didn't engage in prenatal care because they were afraid of experiencing stigma. So again, it can happen in any space in healthcare, and we need to actively counter it in order to prevent outcomes that really could be avoided.
Right. There's this interesting study that you mentioned in a presentation. I thought this was really fascinating. Some listeners might be very familiar with this. They're going to hear me talk probably a little longer than they want. I'm going to set this up for you. But you have talked a little bit, and I've seen this, about the rat park studies, which I found really fascinating. And here's a little background, and by all means, keep me accurate and on track if I get any of this wrong. But in these study experiments by Dr. Bruce Alexander in the 70s, rats were given a large cage with food, a group of other rat community members to socialize with. They also had 2 fluid dispensers. One had a morphine solution, the other had tap water. And Dr. Alexander found that the rats in the large cage with other rats and plenty of socialization and activities actually didn't go for the morphine. But there was another group of rats that was placed in individual isolated cages for the duration of the experiment and ended up taking to the morphine pretty quickly. And there was a 2018 kind of a continuation of the rat park studies, another study titled Volitional Social Interaction Prevents Drug Addiction in Rat Models, where it was taken one step further. And a shock was administered when a rat chose a social interaction versus administration of heroin or methamphetamine. And after receiving the shock, the rat would return to the use of the substance. I know Nora Volkov has said there's a parallel here between that shock and stigma is kind of the equivalent of receiving a shock. Can you share some of your thoughts around this and opinions on the idea of how does environment and social enrichment play a part in addiction and substance use disorder? You know, how do those things speak to maybe the deeper human connection and desire for purpose that is maybe forgotten when it comes to recovery? And what's the alternate path, or what should people dealing with substance use and being hit with that stigma shock, is there a way to build and foster like better outcomes and support systems for them?
Yeah, so I feel like when I was seeing patients clinically, about 90% of my job was helping people to feel better about themselves, because often people who are using and who have experienced stigma, they really have lost that sense of self-purpose and self-worth and don't see themselves as having a meaningful life. And it's just really unfortunate that experiencing stigma could lead somebody to feel that about themselves and then subsequently to continue using. And so when I think about substance use and I think about stigma and I think about social isolation, when we talk about, what is the opposite of addiction, you hear some people say abstinence, and I don't think that way at all. According to Johan Hari, who does a beautiful YouTube segment on actually not YouTube, it's TED Talk, does a beautiful TED Talk on an addiction. He says that the opposite of addiction is connection. And I completely agree with that, because again, if people are isolated, Often people using are using alone. They do not want to use around other people. They don't want people to know that they're using, which obviously puts them at risk for a fatal overdose. But besides that, it reinforces the isolation, the lack of social connection. If they don't feel like they have someone who supports them, it makes it really difficult to want to make any changes in your life or to make any changes successfully in your life. And so I think that if we can help people to develop a healthy community around them that loves them and supports them for who they are, whatever they're doing, and that it's really about them being a human being and about them having worth inherently because they are a human being, that helps people start thinking about possibilities for themselves. And that possibility may be a change in a use pattern. It may be decreased use. It may be ongoing use, but maybe it's using in a safer way or in a way that perhaps isn't as isolating as they had been. And so it is extremely important that we help individuals find their community if they don't already have one. One of the questions I always ask a new patient when I meet them is, who do you turn to when you have a time of need? Who would that be? And I feel more confident for the people who can identify one person or two people or a community versus a person who says no one. I have no one that I can turn to. I really worry more about that person.
Yeah. I want to ask you too, because I've heard, and I think we talked a little bit about this at conference, I've heard a lot of physicians talk about this idea of we need to treat them as a whole person. You know, it's the mental part, the emotional part, all these different things. I want to ask, in your experience, do you think that is this a new concept that's catching on? Has it always been there? You know, and where do you see the state of things right now? Are things improving for patients that are coming in for addiction treatment, or do you think that there's still a long way to go?
I think there's still a very long way to go, unfortunately. I don't know that everybody is using evidence-based practice. I don't think that everyone is using a harm reduction lens. I don't think everyone's using a trauma-informed lens. And I think without those lenses, you're not going to deliver the best care that you could for that person. Is everybody doing whole person care? I don't think it's a new concept. I think it's a concept that's been around. And I think good providers always did whole person care, regardless of what condition they were treating in the patient. But I don't know that in our compartmentalized world of medicine that we do always think about people as whole people. You know, you have your cardiologist and your other specialist and your pulmonologist, et cetera, et cetera. And so each person is taking care of one of your body parts. And I don't think that's a very holistic way. It's obviously we need specialists in certain types of medicine, but it's not a very holistic way of taking care of people. I feel like when I meet with an individual who I'm ostensibly treating for their substance use disorder, we spend a very short amount of time actually talking about what's going on with their use. Most of the time is spent on what do they want out of their life. You know, again, who are you close with? Who can you go to for support? How do you spend your time? What matters to you in your life? I think those questions are a lot more important. And helping people, I think of it as like curating a pathway with people. Helping people along that continuum in their life, it requires you helping them far beyond their substance use. I mean, I can provide them with a tool, buprenorphine, to help their opioid use disorder, but really helping them develop their skills and tools to deal with life, which for many of my patients has been very stressful and often very unpleasant. I would say that nearly 100% of all the patients I've ever treated with substance use disorder have had significant trauma in their lives. So helping them find a lens through which they can address and or cope with what they've experienced in their life, I think is a really probably the most important thing that we can give them.
Yeah. I'm going to shift gears a little bit because there was another very interesting thing we talked about at conference, and I wanted to ask you about. We touched on xylazine and fentanyl and this trend of polysubstance use. So I had cited an article of yours from our blog titled Finding Life-Saving Solutions to a Dangerous Trend. It talks about xylazine, how, you'd said that the majority of the syringes found with fentanyl also contain xylazine. Now, I had asked about this as, was this a purposeful choice in the drug use to impact or extend the high? But you explained, in fact, no, this was not a choice by the user, and it wasn't even being done at the street level, but that it's being added somewhere in the supply chain, and people are ending up with it in the substances they eventually are using. You also said polysubstance use is the most common type of use, and polysubstance overdose is the most common type of overdose. Tell me a little bit about this changing landscape of, adulterants being added to substances and the prevalence of this polysubstance use. What do providers at all levels, from, I remember you mentioned like first responders to physicians, what do they need to understand about the trend? And what can you tell me about this changing landscape, about the substances that are available today? What are these new and emerging dangers? What's the research and approaches in relation to, the developing challenges of polysubstance use?
So polysubstance use has always been the norm, but I think it's just under-recognized as the norm. And because of the way that the drug supply is changing, the drug supply is more volatile and it's more potentially lethal than it used to be. So polysubstance use used to be a not so dangerous way to engage with substances, but now it is more potentially dangerous just because of the potency of the substances that make up the unregulated drug supply. So I think, unfortunately, that polysubstance use and polysubstance overdose are under-recognized across the board. What I've really noticed in the last 10 years is a simplification of overdose response. Particularly during COVID, I first noticed it. So essentially, rescue breathing got eliminated from an overdose prevention training. It really became just focused on naloxone. There's also a perception that because the opioids in the drug supply are more potent, that you need more naloxone. And that's actually not true. That has not been proven to be true. There's a very large growing evidence base that shows that isn't true, but people believe that. And so unfortunately, we're getting newer opioid antagonists, longer acting, like nalmefene, or higher dose naloxone, that pharmaceutical companies are pushing as necessary given the current drug supply. But there are quite a few studies that show the exact opposite. We're really not using more naloxone, and even in the face of more potent, highly potent synthetic opioids. And so what I think is more important is, one, people know how to use naloxone appropriately. And that means you need to give naloxone time to work. So if you come across a person who you think is in an overdose situation, the first response is always going to be to give naloxone, because the vast majority of overdose deaths are associated with highly potent synthetic opioids. So of course you're going to give naloxone, but give naloxone time to work. There's a variety of different descriptions of how long that wait is, but at a minimum it's 2 minutes, but it could be 2 to 5 minutes. While you're waiting, and most people are doing naloxone dose after naloxone dose every 30 seconds to a minute. They're not waiting. And again, in that situation, it is very difficult to tell how long 2 minutes is. So it's why you have a stopwatch, or you have something that you can measure the time on. And you're doing your assessment of the individual while you're waiting for that 2 to 5 minutes to pass. Are they breathing? How many breaths are they taking a minute? Do they have a pulse? Have I called 911, et cetera? So you're giving naloxone, activating 911, doing an assessment. You're giving rescue breaths. If they are really breathing very shallowly or very few times per minute, you want to give rescue breaths. If you have other tools at your disposal and you know how to use them, a pulse oximeter, you're going to pop that onto someone's finger so you can see if their oxygenation is decreasing or if it's already at a very worrisome number. You're going to be, if you have an bag valve mask, or an ambu bag is another name for it, and you know how to use it, you're going to use that to oxygenate for that person. Again, we talked about the other substances that may be involved. So often in the unregulated drug supply, someone may be intentionally trying to use opioids, but mixed in with their opioids are xylazine and some synthetic benzodiazepines. So both of those substances affect breathing by a different mechanism of action than does opioids. So if you give naloxone, that'll work on the opioid portion of the overdose, but it will not do anything to reverse the xylazine component of the overdose or the benzodiazepine component of the overdose. In both of those situations, the tongue, which is a muscle, relaxes under the influence of those substances and blocks the back of the throat. So if you do not do anything to address the tongue that is blocking the back of the throat, doesn't matter if your naloxone is effective to some degree, because again, they're still not going to be able to get oxygen into their lungs. So it's important that you do a head tilt and a chin lift or put them in a recovery position to try to move that tongue out of the way. And depending on where you are, you might have access to oxygen. So oxygen is another great way to support that person's respiratory system, make sure that oxygen is getting to their heart and to their brain. And in that overdose situation, in a situation where xylazine is on board, for example, that person may be unconscious anywhere from 4 hours to 10 hours. So they are not going to wake up. So another thing is that people are expecting sort of the old opioid reversal situation to be occurring now. And we're in a different situation now. So that person's not going to wake up and be walking and talking. They may be breathing normally, but not wake up. And you can give them naloxone till the cows come home. They are not going to wake up from the naloxone. So it's important too that we also think about the impact that our intervention has on the person who's experiencing an overdose. So you want to give enough naloxone that normalizes their breathing and then do those other maneuvers to support their airway and breathing. But we do not want to give too much naloxone or more naloxone than necessary and then put them into severe precipitated opioid withdrawal, which will make them reluctant to carry naloxone or to have naloxone administered. Some people in qualitative studies have said that they tell their friends not to give them naloxone if they overdose because they don't want to experience precipitated withdrawal. So again, when we're thinking about our response, we want to be the most effective we can be, but we also want to be the most compassionate that we can be. So we recognize that what this does in this situation is if we give, the more of a dose we give of naloxone, or nalmefene, the more we give, the more of an effect that will have on the person who's physiologically dependent on opioids. So if we can titrate our response, then that might be a response which is far better tolerated by the individual who's experiencing the overdose.
You just mentioned compassionate care, and I know we've talked about treating the whole person. You've noted, and I love this, you said recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And this may or may not include abstinence from substance use. And you cite the 4 big pillars of recovery as health, home, purpose, and community. I love that. Talk to me about the idea of this individualized recovery. Why is it so important to address each person as an individual with unique needs? And tell me about these 4, pillars of recovery. What's involved with finding fulfillment in these areas for patients? Have you found, and why are these specific needs so important to a person's long-term recovery?
So I didn't come up with that. That comes from SAMHSA. I abridged it from SAMHSA. So I just want to give credit where credit's due.
Gotcha. Okay.
But I do think it's really important because I think historically the focus in the substance use disorder treatment community has really been just a dichotomy. You use or you're abstinent. And that's not how people's lives are. People's lives are all along the continuum of use, from abstinence all the way to chaotic use. And so people go back and forth on that continuum all the time. And what I think is more important than whether somebody is using or not is, are they able to have a quality of life that's meaningful to them? And so the pillars are really about different facets of our life that I think need to be addressed when we're talking about addressing somebody with substance use disorder. So just to give an example, so if a person becomes abstinent, but they have no place to live and they have no support in their life and they don't feel like their life is meaningful, then how meaningful is that abstinence? So the point being that we have to think of people as complex beings. We have to think of quality of life as defined by the person who we're doing care with or engaged with. So I have no right to define for you what your quality of life is and what it should be. So it's really important when you're working with patients with substance use that you talk with them and together define the goals. And so that goal for one patient may be abstinence. Maybe they want to stop using all substances. For another patient, maybe they don't want to use opioids because they're afraid of fatal overdose, but they want to continue using another substance. Or maybe they just want to use in a way that it's not so chaotic in their life. Maybe they want to get their kids back into their custody. Maybe they want to go to school. Maybe they want to open a barber shop. Maybe they want to get their teeth fixed. Regardless, it's going to be an individual goal that, again, that patient defines. And I'm not going to know what that goal is without having that in-depth conversation with a patient. So I think the days where literally the historical goal in many substance use programs is just that everybody becomes abstinent, that's not adequate in today's day and age. And we really need to be having individualized goals with patients. And so those 4 pillars. So if you think about home, many of my patients were unstably housed, unhoused, or unsafely housed. And so we have a huge housing crisis in the United States, as in many other parts of the world. But again, people who are actively using have a difficult time securing housing. And a lot of that has to do with abstinence-based housing, which, again, I come from a housing first mentality. So meaning that people should be able to be housed first. Someone's far more likely to even think about, on their hierarchy of needs, addressing their substance use when they have a safe and stable place to stay. If you don't have a safe and stable place to stay, then often using as a coping mechanism for dealing with the fact that you have an unstable and unsafe place to stay. So home is really important, a place where people, again, maybe with or without other people, but that they feel safe and supported and stable. In other words, that housing is not going to be pulled out underneath them because they have a positive toxicology test. The second pillar is health. So often when folks are actively using, sometimes they may not be able to address their health issues because, again, of the other competing needs in their lives. But sometimes if you're able to engage somebody, and for example, my best example is treating hepatitis C. So someone who's actively using, not interested at all in addressing their substance use, but they do want their hepatitis C treated. So you treat their hepatitis C, they're cured of their hepatitis C, and then often they may have a little bit more interest in looking at other things in their life now that you've successfully addressed that health need. So again, remembering that something like treating hepatitis C is very, very low threshold, and even if someone's actively using, they can successfully treat their hepatitis C. It's a short treatment and it's a very effective treatment. And doing something like that will likely make somebody feel better about themselves. So those are the first 2 pillars. And then there's community and purpose. So sort of what I was talking about earlier with respect to community, people need to have people in their court, people who support them, people who love them, no matter what happens in their life, no matter what is going on in their life. And often when I initially meet patients, they may or may not have community around them. And for some folks, for instance, the harm reduction program where they go and they exchange their syringes is their community, and that is their safe place. For other people, it's family who have never turned their backs on them, or a partner, etc. But for some folks, unfortunately, the bridges have been burned in a lot of their relationships, or they're engaged in unhealthy relationships that are not supportive. I particularly have seen that with women who are stuck in a cycle of intimate partner violence and substance use, and really don't know where to turn to. And then lastly, it's having purpose or meaning in your life. So I think about that as, if you wake up every day and you don't see that there was a purpose to you waking up, it's, again, going to be really hard to think about anything changing in your life. So it's instilling confidence and self-worth in people, and helping them see their own self-worth so that they realize that they can have goals and they can have dreams, and that those can be achieved. And so it's helping people find those dreams, and then helping them, as you're able to, move towards achieving those dreams. And it could be baby steps, but helping them see that there is more to life than perhaps they're experiencing right now.
Dr. Kelly Ramsey, it's been a pleasure catching up with you again. Thank you so much for taking the time to come on and do another episode with me.
Thank you so much.
Another big thank you going out to Dr. Ramsey. Thank you for coming on the show and sharing all this great information with us. We appreciate your time. We sure hope that you guys enjoyed this episode, and hey, maybe you learned something along the way too. That's always an added bonus, right? If you or someone you know is struggling with addiction, we want you to know that you are not alone. Treatment is available and recovery is possible. Visit the link in our show notes to access patient resources like our physician directory, patient and family support groups, and much more. And that's the show for today. Thank you for taking the time to hang out with me for a little while. I sure do appreciate the support. I am out of here, my friends. Be well, and we'll see you in the next episode.